Dr. Vin Tangpricha. Vin is an associate professor in our division and is also the director of our training program in endocrinology, in addition to being the director of the science track of the medicine residency. Vin got his residency and fellowship in endocrinology at Boston University. He also got a PhD studying vitamin D there. He came to us and became quite established as clinical translational investigators in the area of vitamin D, but he also had a second interest in transgender medicine. He is, in fact, a member of the Endocrine Society Guideline Committee for Transgender Medicine, and is in the board of director of the World Professional Association for Transgender Health. So he's quite an expert in this area. So Vin, thank you for sharing your knowledge with us, and welcome.
Thanks, Roberto, for the introduction. So I wanted to start off with just telling people about how I got in this field. And so it basically started off as during my intern year at Boston City Hospital, and I was a budding endocrinologist at that time, and very aggressive with getting patients into my continuity clinic. And I encountered a person who's transgender on my service, and I invited her to come to my continuity clinic. But at the time, there wasn't really much written about how to take care of transgender people. And so I went around the city. That was pre-PubMed and free downloads. Went around the city, went to the Countway Library, different libraries around the city of Boston, and Xeroxed many articles. Gave my senior talk on transgender medicine, and actually wrote a review in our clinical endocrinology journal. And at the time, there weren't that many reviews. And a year passed, and then I was asked to write guidelines for the Endocrine Society. It's always, I just give that story because for house staff, you don't know what can happen. I mean, if there's an interest that you have, pursue it, publish it, and it may be an academic niche for you in the future. I also wanted something a little bit different from my mentor who was doing vitamin D research, and I thought transgender health would be a perfect subject. So I've been in this field about 20 years, and it's really amazing to see how this has really grown. And so what I'm going to do today is just give everyone an update of what's happened in the field. I don't have any disclosures. And so my learning objectives are that I'm going to help you cover the guidelines and review the available resources for diagnosis and treatment of patients with transgender. We'll describe the initiation and monitoring of hormone therapy in patients with transgender and identify some of the risks of hormone therapy with people with transgender. And before I start going with my talk, can I just see a show of hands? How many people have encountered a transgender patient? Okay, great. So that's much better from a few years ago. This is my agenda. We'll go over the timeline of transgender medicine. We'll have to cover some of the terminology before I go through my case presentation. We'll discuss health disparities in the transgender population, discuss guidelines and best practices, and we have some data on longitudinal health risks, and we'll conclude. So the field of transgender medicine is relatively new. It's less than 100 years old. The first physician who was credited for the term transgender or transsexual is a physician from Germany, Magnus Hirschfeld, and he's credited as the first physician to give a patient hormones for gender conversion therapy. In 1952, Christine Jorgensen, a former military veteran, made front page news for changing her gender, and that was the first public awareness that people could be transgender in the United States. In 1966, Harry Benjamin was an endocrinologist who published protocols on how to treat transgender patients, and the gender center at Hopkins opened up, and that was the first dedicated gender clinic in the country. Things start to move along a little quicker. In 1979, standards of care were released by the World Professional Association for Transgender Health, also called WPATH. And in 2009, the Endocrine Society released hormonal guidelines for transgender people. Finally, in 2011, the VA released a memo stating that veterans could be treated with hormones to change their gender. The IM released a report saying transgender people need more health care and there are health disparities. And the new guidelines for WPATH were released just down the street in 2011 at the Emory Conference Center Hotel when they held their annual meeting. 2014, Time magazine had the first transgender patient or person on their front cover, and Medicare released guidance that you couldn't discriminate on transgender status for all their patients. I think the biggest tipping point for the field was in July 2014 when Caitlyn Jenner came out as being transgender, and I think there's been, since then, continued interest in this area. And also the same month, a child, Jazz Jennings, came out as the first publicly open transgender child, and she had a reality show, I Am Jazz, that really raised awareness about transgender children, and she actually came to speak to us at the Endocrine meetings in 2016, and that's just a picture of her family and Endocrine's ACE president. Just to cover the last year, as everyone knows, the North Carolina bill, March 2016, was released, forcing trans people to use the bathroom of their birth certificate. The Pentagon released their ban in July 2016 on transgender troops and started to offer surgery for all transgender active duty military. And just recently, the bathroom bill in North Carolina was repealed. So there continues to be a lot of action in the transgender community, and I think it's going to continue. There is a big transgender rights movement. Trans people want to they have equal care and receive equal rights and gender-affirming care and therapy. So before I go in my case, I have to cover some basic terminology. So what is sex? So sex are the attributes that characterize biological maleness or femaleness. That's usually based on your internal, external genitalia and secondary sex characteristics. So some examples are male sex, female sex. Natal sex or sex assigned at birth is the sex that you were given at birth, usually based on your anatomy, either male or female. Gender is the attitudes, feelings, and behaviors that are given culture associates with a person's birth sex. And gender identity is one internal, deeply held sense of one's own gender. So what is transgender? So transgender people express a gender identity that does not match the sex that was assigned at birth. Most people have a gender identity of a man or a woman, boy or girl, and that's considered a binary identification, but there are people that don't have a binary identification, and these are people called gender nonconforming, that have behaviors that are incompatible with either male or female. And we won't talk too much about this group, but we'll focus mostly on transgender people. Cisgender is a term that's recently developed for people who express their gender identity as their sex assigned at birth. We won't go over all these guidelines from the DSM-5, but there are criteria to diagnose gender dysphoria in adults. Essentially, a person is considered gender dysphoric if they strongly feel that they want to be the opposite gender. So that leads into my case. So this is a true case seen in the Atlanta area. A 51-year-old trans male, so sex assigned at birth female, converting to male, presents to your office for evaluation of hormone therapy. He has been taking testosterone over the past 4 years. He reports having about a 20-pound weight loss and intermittent abdominal pain associated with nausea and irregular vaginal bleeding. Patient has not had any other gender-affirming surgeries. Past medical history, COPD, medication, testosterone, 100 milligrams every 10 days. Social history, smokes a pack per day. Family history is negative. Exam, very thin, frail, appearing male. Height 5'6", weight 110 pounds, BMI 17.8. Abdominal exam, slightly distended, diffuse discomfort to palpation. The CT scan of the abdomen showed a very large left-sided ovarian mass with ascites. Diagnosis was ovarian carcinoma. So these are quotes from the patient's family. Patient tried to get a GYN appointment at Emory Midtown, Piedmont, Grady. Also tried to be seen by 20 different private practice GYNs in Atlanta, but all denied him an appointment. He did find one GYN that was willing to see him, but the doctor was 3 hours away. Further, the doctor said that the patient should be ashamed of himself for living as a man, and insisted that he had to see a psychologist to accept and acknowledge that he was indeed female. This was a prerequisite before the doctor would treat him for his ovarian cancer. The patient, knew that this was ludicrous and was insulted. He refused to see the psychologist and left the doctor's office. Because he was so frail and seriously ill, the doctor called the police, who arrived and confronted Robert. They insisted that he had to go back to the doctor's office. He refused again. The police manhandled him, and Robert ended up in the emergency department with serious injuries. And so that was the story of Robert Eads, a true a case that happened about 15 years ago in Atlanta, and eventually made into a movie produced by HBO. And I just want to show a little clip from Robert describing his encounter with the healthcare system.
It's Easter morning, and it's sunrise. And I wish I could understand why they did what they did, and why they had to feel that way. And I know in a way they've contributed to my dying here. But I can't hate them. I don't hate them. I feel sorry for them. I can't say I actually forgive them for what they've done. I think that's more between them and God. But I don't hate them. I guess what makes me most sad is that they probably feel like they did the right thing.
So he never got the care he needed, and you may say it was over 15 years ago. So what's the situation now? And transgender patients still face a lot of discrimination. This was a survey done a few years ago, surveying over 6,000 transgender and gender nonconforming people, and found that over half of people lost their job because of gender bias. 60% were a victim of sexual assault, 60% are victims of physical assault, nearly 60% had family rejection, and 20% experienced domestic violence. So a lot of discrimination in the trans community. This is data, same survey, but of children, and school-age children report many assaults at school. Over 70% are harassed, 30% are physically assaulted, even nearly 10% are sexually assaulted. And what's most surprising is that 30% are harassed by teachers or staff. From the same survey, transgender people report discrimination in public. Retail stores, 30% report being harassed or denied equal treatment, even by police officers, 20 to 30%. What about physicians? Not much better. Doctor's office or hospital, about 20-25% report being harassed or denied equal treatment. And that's pretty comparable to a hotel, restaurant, or bus or train. So I think we have to do a much better job in the medical community. And transgender people avoid healthcare providers because of this mistreatment. 1/4 of transgender people avoid coming to see doctors because of fear of mistreatment. And this is pretty much across the board in different races and ethnicities. Transgender people have very high rates of suicide. In the National Transgender Health Survey, 40% of transgender people reported a past suicide attempt, compared with only 1.6% of the U.S. population. And factors associated with increased risk of suicide are physical and sexual violence and discrimination. There's been a lot of study at the VA, and this was a study conducted in the VA healthcare system from 2000 to 2009. Over 5,000 transgender veterans identified by ICD-9 codes, and the risk of death for being transgender was much elevated, almost threefold compared to the non-transgender veterans, and much elevated compared to the U.S. population. Why are physicians and healthcare providers discriminatory? Part of the reason probably is just inadequate medical education and training. Only 1/3 of medical schools cover medical therapy of transgender people, and only 70% of endocrine training programs have it in their curriculum. And a survey of local endocrinologists attending a meeting, only 20% felt comfortable treating transgender people. I think at Emory there's only an hour lunchtime lecture given to our students on transgender medicine. You may ask, what is the prevalence of transgender in the United States? And this was a study done from UCLA Williams Institute, who estimated, compared to the LGB population, where 3% of the U.S. population are LGB, about 0.3% of the U.S. population are transgender, so roughly equates to 700,000 Americans. And most recently, they've updated their estimate to 1.4 million adults in the United States are transgender or gender nonconforming. I think the prevalence of transgender depends on the definition, and this is a study we published with Mike Goodman at Emory School of Public Health. If you define the people as transgender as those who request surgery, you have a lower estimate, maybe 5 to 10 out of 100,000 people are transgender. If you use ICD-9 codes, maybe 2 to 10 people out of 100,000 are transgender. But if you look at self-reports or surveys, it's a much larger number, 500 to 750 per 100,000 are transgender. There's been a study looking at the prevalence of transgender in the VA healthcare system, and they simply looked at 3 ICD-9 codes associated with transgender and searched the VA database from 2006 to 2013. And you were considered if you were transgender if you had one of those codes at any time. And so this is their data. You can see over time from 2006 to 2013, the prevalence of transgender increased in the VA, and the most recent number is about 33 patients out of 100,000 veterans were transgender, and that represents 0.03 of the VA population. But there's some weaknesses with this data search. It only goes by ICD-9 codes. Some patients may be transgender and not seek care for that transgender condition, and so it misses a lot of people. So working with Mike Goodman and the Emory School of Public Health, we were funded to look at the prevalence of transgender in the Kaiser healthcare system. And the overall goals of this grant was an R21 and PCORI grant. We wanted to look at the prevalence of transgender in a large integrated healthcare system, and we wanted to provide long-term data on the health status of transgender and gender nonconforming people. So our study was a little bit different from the VA studies. We did use ICD-9 codes, but in addition we use keyword searches in the medical record. So we could pull out if the word transgender, transsexual, gender identity, and other keywords were in the medical record. But in order to confirm that they were truly referring to the patient, we looked at text strings before and after that word, because it could be sister was transgender, and we didn't want to misclassify the patient. So it picked up a lot more people that were transgender. So these were the data. This is the Northern California Kaiser data. You can see from 2006 to 2014, the prevalence of transgender in the female to male population roughly is about 70 per 100,000. For the male to female population, close to 80 per 100,000 people. That was Northern California, so that included San Francisco, Sacramento. Southern California, the prevalence for female to male was roughly 30 per 100,000, and for the male to female, 50 per 100,000. And you can see in both cohorts, the prevalence started to go up per year. This is looking by age, and if you break down by 5 different age categories, you can see in the younger category, 18 to 25, 160 people per 100,000 were classified as transgender. The number goes down a little bit as people age, and we believe that's because the recent acceptance of being transgender in the younger populations. If you look at the overall prevalence of transgender in Northern California population, about 80 per 100,000 people. Southern California, the same trend. We saw much higher rates of transgender in the younger age group and seemed to go down by older age group, but the overall prevalence was 50 per 100,000 people. So if you use a number of about 100 per 100,000 people are transgender, or 0.1%, there are roughly 250,000 people that are transgender in the United States. There are some limitations with the estimate. This does not include children. This was only an adult study. Doesn't include those who are not seeking medical treatment or don't want their identity undiscovered. Many health providers don't use those mental health codes when seeing patients in the clinic, so many people are missed in these studies. And this cohort may not be fully representative of the U.S. population. The Kaiser healthcare system is a highly insured, much more higher socioeconomic status population, so it may not apply to you may not be able to use these data to apply to the Grady population or other urban-type populations. The etiology of transgender is unknown. There may be cultural, genetic, biological, hormonal, psychological factors. We don't really know what causes transgender. There are some studies that suggest that there is a biologic basis. This is an example of a twin study where they identified a person who had at least one person out of the twin was transgender, and they simply looked if there was concordance or discordance in the monozygotic or dizygotic twins. If you look among the monozygotic twins, i.e. identical twins, 40% of the time the other twin was transgender. If you looked at the dizygotic twins, none of the dizygotic twins had a transgender twin. So that suggests that there is some genetic component to being transgender. People have looked at different polymorphisms in genes that may explain transgender, and there seems to be some relation to the estrogen receptor beta in trans males and the androgen receptor in trans females. Does not seem to be any association with the aromatase enzyme, the enzyme that converts estrogen to testosterone. There is an area in the brain that may also predict gender orientation, and these were studies done years ago looking at brain sections post-mortem of people who are non-transgender and transgender, and you can see in a person identifying as male, there's many more neurons in this area compared to a person identifying as female. A gay male has the same number of neurons as a male because it's thought that the gender identity is still male, but the trans female has the same number of neurons in a trans woman. So some investigators have thought maybe this is the center of the brain that controls gender identity. So what do the guidelines say? So everyone should be aware of different guidelines that are out there for treatment of transgender people, and the first set of guidelines are released by the World Professional Association of Transgender Health. This is the largest organization of professionals in the United States, about 2,000 members. They first published guidelines in 1979 and basically deal with everything in terms of diagnosis, who's eligible, how to monitor hormones in transgender people. And so these guidelines that were last released in 2011 at Emory say that you have to have very well-documented persistent gender dysphoria. You have to be able to decide and make a more informed decision for treatment with hormones. You have to be of the age of consent in the United States. So in the United States, it's 18 without your parents to receive hormone therapy. And you have to have all your medical and mental health concerns addressed before going on hormone therapy. The major changes from the last time was they didn't require a letter. It used to be you had to have a letter from a mental health therapist certifying that you could go on hormones. The committee removed that because they felt that would be a barrier, especially in areas that didn't have a specialist that specialized in making the diagnosis, and felt like the physician could, with adequate training, make the diagnosis without being a mental health provider. There's much more emphasis on informed consent, and they removed the requirement of real-life experience, which meant that people had to live in that gender role for a year before going on hormones, and that was a challenge for many people, so they removed that requirement. Some of the other highlights of the new standards, the term disorder is not a term that should be used. It should be now gender nonconformity. Being transgender is not pathologic. It's just a different form of gender expression. As I mentioned, psychotherapy wasn't an absolute requirement, and the guidelines were more accepting of other forms of gender variance. And there were more sections on how to deal with children and reproductive health, and define who were the gender experts. The Endocrine Society guidelines released in around 2009, and the update is due this year, and basically cover the hormone treatment of transgender people, and basically how to screen and monitor for potential complications. I'll quickly go over some of the hormonal regimens. There are basically three different age groups. So children and adolescents, earlier than Tanner stage 2 puberty. For the trans female, estrogen therapy is not recommended at that time because the person has not gone through puberty. But what is recommended is delaying the puberty. So GnRH agonists are recommended to buy the child some time to work out their gender identity. For adolescents presenting after Tanner stage 2, estrogen in different forms can be recommended, along with GnRH agonists to help delay the puberty. In adults presenting after puberty, there are two different regimens. The estrogen in different formulations, oral, transdermal shots are recommended, and you need a testosterone blocker, either a GnRH agonist, which is used in the UK, but not here in the United States because of costs. But the most common testosterone blocker in the United States is spironolactone, usually in much higher doses than you use for other conditions, but in the range of 50 to 400 milligrams daily. The effects of hormone feminization usually takes some time, and it's important to cover this with your patient. It could take up to 2 or 3 years to have its full effect. The onset is within a few months, usually 3 to 6 months. You'll have some changes in skin, breasts, muscle mass, but these effects don't really reach a maximum until 2 to 3 years later. It's also important to set realistic expectations with the patient. Sometimes some of these don't fully develop. So monitoring, patients should be seen every 2 or 3 months in the first year, and then annually or semi-annually to measure their estradiol and testosterone levels to make sure they're in the correct range for the desired gender. Patients on spironolactone should have their electrolytes measured, and cancer screening should be done according to age-appropriate guidelines with the remaining hormone-sensitive organs. And if there are risk factors for osteoporosis, consider a bone density. There are some risks with trans feminine hormone therapy. Some of the things that are likely increased are DVT and PE, gallstones, weight gain, hypertriglyceridemia. There's possible increased risk with hypertension, prolactinoma, and breast cancer. We're unclear about the liver function test risks. In the trans masculine hormone therapy, the same. There are 3 different age categories. Children, adolescents presenting before puberty, not recommending testosterone therapy, but recommending GnRH agonists to block puberty to allow the child to fully work out their gender. People presenting after puberty in childhood, testosterone can be started at low dosages along with GnRH agonists, or patch or gel can be given. And adults and adolescents presenting after puberty, shots or gels can be given, and usually GnRH agonists are not required at that time because testosterone usually can overcome the effects of estrogen. Same with the trans female. The trans masculine effects occur over time and won't reach a maximum until 2 to 5 years later. But some of the changes include changes in skin. There may be acne, hair loss. Sensation of menses occurs very quickly within 2 or 3 months. For the trans masculine person, patients should be evaluated every 2 or 3 months in the first year, and then annually, and then semi-annually. Measure the testosterone every 2 to 3 months until it's in the physiologic male range. Measure estradiol levels for the first 6 months to make sure that, or until there's no more uterine bleeding. And we measure CBC for risks of polycythemia as well as liver function tests, and consider bone density or mammogram if breast tissue. Again, we have to continue screening for cancer for those remaining organs for hormone-sensitive cancer. The potential risks with trans-masculine hormone therapy likely increased are polycythemia, weight gain, acne, or sleep apnea. Possibly increased are lipid abnormalities, and we don't really know much about the cancer risks, but I'll have some data at the end. There have been some long-term studies, and these are 2 studies commissioned by the Endocrine Society. The first study was the committee asked a Mayo clinical evidence group to review the risk on cardiovascular disease and hormone therapy. And from a meta-analysis of several different studies, there was inconclusive evidence for increased or decreased risk with hormone therapy. In terms of quality of life, there appears to be an 80% improvement of gender dysphoria based on a meta-analysis of several different studies. This is probably the most recent and probably best study looking at quality of life and mental health in transgender people. This was published from Italy. They followed transgender individuals and took very detailed quality of life questionnaires and found that, in general, people who started on cross-hormone therapy had improvement of their gender dysphoria and depressive symptoms. The risk of DVT-PE is a big concern in trans women. This is a list of studies that looked at the risk of DVT-PE. You can see the earlier studies showed a very high risk of lifetime DVT-PE, about 5%, and that was published out of the Netherlands. And it's thought to be because of the estrogen that was used. They use estradiol, which is thought to be much more pro-thrombogenic. And since then, they've stopped using that form of estrogen, and the risk seems to be much lower. In Germany, they reported only 1 out of 60 trans women had a DVT or PE, and the one person who had a DVT or PE had a predisposition to having DVT or PE. In Austria, no one developed a DVT or PE, and what's unique about that population is they use strictly transdermal estrogen, so that might be much safer. In Belgium, they reported 3 out of 50 trans women having DVT or PE, but out of those 3, 2 were smokers. The most recent data seems to be from this group, multinational group, including Emory, 9 European and 6 U.S. sites. Only 10 out of 1,000 people had DVT or PE. So I think under regular monitoring in a healthcare setting, the risk of DVT or PE seems to be very low. This may underestimate a little bit because there may be issues with loss to follow-up in some of these cohorts. So we also looked at the Kaiser database, and this is some of the initial data that have come out. From the cohort that were identified as being trans-feminine, we looked at different cancers, and you can see here the rate of cancer, looking at some of the most common cancers: prostate, skin, lung, colorectal, hematologic, lymphatic, thyroid, other endocrine. It didn't seem like there was increased risk of cancer compared to in the trans-feminine population compared to non-trans males or non-trans females. And also note the breast cancer. There was very few breast cancers reported in the trans-feminine population. In the trans-male population, you can see here breast, skin, cervix, thyroid. The risk of these cancers were very similar to non-transgender males and non-transgender females. So the risks on long-term risks seem to be pretty good in terms of cardiovascular and cancer risks. We will have data on DVT and PE risks shortly, and other risks like bone health risks and many other risks. So in summary, transgender people face very high rates of discrimination and increased rates of suicide, depression. The prevalence of gender variance is unknown in the United States, but suggests that the prevalence of transgender is roughly 50 to 100 per 100,000 people. The etiology of gender dysphoria is unknown, but likely has a biologic basis. And I think physicians just need to have a basic understanding of some of the healthcare issues facing gender variant people. The long-term safety of hormone therapies appears to be pretty safe, but we need to have more long-term data, including large cohorts such as the Kaiser cohort and other cohorts. And so happy to take any questions. Thank you very much for your attention. Carlos. Mm-hmm.
The issues of how you address the patient comes up. I guess this is working now.
Okay.
The issue is how do you address the patients, but the other issue is how do you document it in the medical record, because as far as I'm aware, neither Cerner nor Epic, they have the capability, but our systems have not activated the feature that allows you to actually design sex versus gender on the medical record. Mm-hmm. And that creates a problem as far as knowing what to do with the patient. And also the other issues around lab values. Which lab value do you look at? Is it normal for a female or for a male? And how do you look at those issues?
Yep. So I guess the question is, how do you address the patient? So if you're seeing a new patient, I usually try to ask, I'm enriched in a lot of transgender patients in my clinic, so I'm maybe at a slight advantage to you, but I usually come in the room and introduce myself and then ask how they like to be addressed, and then ask what pronoun they want to use. In terms of the the gender in the electronic medical record, I know at Emory, if you come in with a letter from the court saying your gender should be male or female, they'll change it in the chart. Same with the VA. You can have your gender marker changed. But that does take a little bit of effort to have that changed. In terms of the lab values, we did look at that. We published with Colleen Kraft here at Emory, and there is some differences. We don't know yet what is the appropriate level to use. Really, like there are differences in hematocrit, liver function tests, creatinine. So it's we don't yet have a standard for that.
Obviously interesting and difficult patients to deal with, difficult in the sense of complexity. But it's also an interesting experiment, if you want, an interesting model to resolve all question about sexual dimorphism. You have a genetic sex and an hormonal pattern of the opposite sex. And so as that led to unexpected discovery or as resolved questions about sexual dimorphism?
That's a good question. I don't know yet if it's kind of challenging because right now we have many people that have been treated as adults who've been exposed to the hormone that wasn't desired and then changed. But I think in the future, I think when children aren't allowed to go through puberty, you may be able to answer those questions better. There was a lot of discussion at last week's Endocrine Society meeting to discuss different hormones that affect your gender orientation, but I don't think there really has been much progress in the area.
Yeah, thank you.
Vin, thank you for a great presentation. I had a question on behalf of myself and others as physicians and also our resident physicians, as we are all leaders in some capacity within our healthcare system. And I think that a lot of that information that you presented in the beginning was particularly impactful, especially the discrimination and harassment that these patients face when they come to a hospital setting. I've seen that firsthand since your clinic is right next to my clinic. And I've actually had some discussions with my staff about how they should conduct themselves when your patients come to see you. But do you have recommendations for us as leaders in how we should engage interprofessionally with others to make our hospital settings a more welcoming place for these patients? And how have you done that?
That's a good question. I think I got really good advice from Mark Naines at the chief of VA, and I asked him, how do you feel about me taking care of transgender veterans here? And he said, treat them like people. And so that's a simple advice. I mean, they're coming here, for treatment. They're very vulnerable. They're probably the last group discriminated against in the United States, and we just have to treat them like people, and they're here to seek our care.
Hey, I'm in the Office of Compliance here, and I'm actually heading up changing the ability to change the identifiers in the system. So we're working on that now, and we have a team that's doing that. And we also have a team that's working on sensitivity training. So we should be rolling those out this summer, hopefully. But my question for you was, with creating that stuff in the system, aren't there a lot of different identifiers, and are there preferred identifiers now? Obviously there's male, female, prefer not to identify, and then maybe male transitioning female, or I'm just wondering if there are some actual solid medical terms that we can use when we're creating the drop-down menu, because we are kind of just trying to figure it out on our own.
Yeah, I think there is a good resource from GLAMA that had a web page of different gender markers that could be used. So
Okay.
Yeah,
I've seen that PowerPoint. I didn't know if there was something more, but and if you wouldn't mind touching base with me afterward, because we're trying to develop training.
Do we have any other remote questions or anything there? We got our chief resident on the electronics there. We've got one. All right, there we go.
Here's a question from Grady. For transgender females, do they administer aromatase inhibitors alongside testosterone to inhibit estrogenic conversion? And for transgender males, how do they address the effects of both testosterone and estrogen on growth plate while administering?
So for the first question, we don't use aromatase inhibitors for trans males because both males and females need estrogen. So that would result in very severe osteoporosis. And the effects of testosterone pretty much overpower any the female residual female effects from estradiol, because estradiol levels will go down with testosterone. And the second question was, administer growth plate. I don't know the answer. What was the? I don't know exactly what the question was, but.
Thank you.
Will estrogen arrest the growth in children? Yeah, estrogen will mature the skeleton quicker. That could be a problem.
You may have decided not to present it at this conference, but at what point during the treatment and what are the conditions when some surgical correction of the external genitalia is considered?
So the question is surgery, and this has been a moving target. In the United States, it's felt that you need to reach, age of 21 or older. That age has been moving down gradually. I know for certain everyone wants to have you on hormones for at least a year and make sure you're doing okay. But that there are cases of children having surgery, and so that is a very somewhat controversial area because there is a certain age where gender identity is not yet solidified. And so data from Holland suggests that after age 14, your gender is pretty fixed. So I think most people would feel comfortable maybe 14 and above to do surgery, but there are people pushing the envelope to do it sooner. So for that, I think that would be only like for research questions.
One other question from Grady, more of a practical question, is for patients presenting to Grady Clinic, specifically the primary care clinic, how would you suggest residents plug them into expert care?
Well, I know that there is going to be a Grady clinic started soon, and I'm assuming Jason is in the room there at Grady, but he will be starting a transgender clinic along with other, not just Jason, but many other specialties, including GYN, endocrine. And so I think if a resident gets a transgender patient, either refer them to the Grady clinic or maybe page one of us. We can help you walk through it. I think that the movement has been that you don't have to see an endocrinologist. You could be comfortable in this and learn and treat people that are transgender. But still, there's a lot of people that need to be trained, so it's going to be a while.
Okay. Well, Ben, I just want to join Roberto and thank you for a really interesting and really topical grand rounds. Thanks. Really good.